Welcome to Hawthorn University, everybody. I'm Paula Bartholomew, and I'm always delighted when you join me early for some holistic health updates. And we'll do this before our webinar starts. We've got Kelly Brogan with us today, presenting on ancestral psychiatry. But first, I just want to remind you that we muted you all again, and we do that intentionally so that we can have a very clean audio sound for all of us. But we do encourage your participation always. Please post your comments or your questions at any time during the presentation. And Dr. Brogan is indicating don't be shy about your questions, and you don't have to wait until the very end. So if you want to get your question in first, just go ahead and post it. Alex will be posting information to the webinar panel throughout the presentation too, so if there's any URLs or anything that Dr. Brogan is referring to, Alex will have that there for your convenience. Just a couple of things. Our last webinar was with Tammy Chu, and she was presenting on obesity and the gut microbiome. It was a terrific presentation. We recorded that webinar, and we're going to be recording this one too, so you'll have access them from our website under archived webinars. If you don't know about All About Alumni, it's another online event that I do that showcases Hawthorn graduates. It's a 30-minute segment that we run on the first Wednesday of the month at 12 noon Pacific time. It's just great to hear from our graduates and their success stories and what challenges they've learned from, and it's very inspiring and encouraging, so I hope you'll join me. Our last one was October 5th with Megan Fisher. She was presenting on holistic health fitness, evolving your niche in whole health in a red state. And that was very informative. And coming up November 2nd, we've got Rebecca Katz back with us. She'll be on live at 12 noon. And Rebecca just published her 5th book. It's a bestseller, as they all are. And she's running her very successful Cooking for Healing Cancer series right now. So she'll have a lot to share, and I hope you'll join me for that. It's always a good lunchtime opportunity. So I won't be eating, but you can prep some food and join us. That's Wednesday, November 2nd at noon Pacific. That's our next one. And as usual, we're going to have a survey for you to fill out after the webinar ends. It's your opportunity to give us your feedback on this presentation and let us know about what you'd like to learn more of in upcoming webinars. We do this to serve your interests. So speak to me, let me know what you'd like, and I'll do my best to pay attention to that and fill the spots with people you want to hear more about. Okay, that's it. I'm going to move into introducing our presentation for today. So for those of you that have just joined me, I want to welcome you to Hawthorn University's webinar series. Thanks for joining us. I'll be the moderator for this webinar, and today Hawthorn welcomes Dr. Kelly Brogan. She's going to be addressing ancestral psychiatry and the role of depression and choosing natural medications for optimal results. In this webinar presentation, we're going to explore the literature that undermines the safety and efficacy claims. We're going to focus on long-term outcomes and relapse risk. We're going to gain some familiarity with physiologic imbalances that can manifest as depression and anxiety, such as thyroid imbalance, dysglycemia, or food intolerances, all of these that are modifiable through diet and lifestyle interventions. And then the theory and application of cytokine models of depression and the relevance of gut-brain axis will be discussed. And we're going to learn about the evidence to support the considerations of nutritional factors and non-medication interventions for the treatment of depressive and anxiety symptoms. All this is with Dr. Kelly Brogan, who's a Manhattan-based holistic women's health psychiatrist and the author of the groundbreaking, fantastic book, A Mind of Your Own, and co-author of the landmark textbook, Integrative Therapies for Depression. She completed her psychiatric training and fellowship at NYU Medical Center after graduating from Cornell University Medical College. She also has a BS from MIT in systems neuroscience, and she's board certified in psychiatry, psychosomatic medicine, and integrative holistic medicine, and is specialized in root cause resolution approach to psychiatric symptom and syndromes. She's on the board of GreenMed Info, Functional Medicine University, Pathways to Family Wellness, NYS Perinatal Association, Price Ponizer Nutrition Foundation, and the Mind Foundation, as well as peer-reviewed indexed journal Alternative Therapies in Health Medicine. In other words, Dr. Kelly Brogan is extremely qualified, is extremely smart, is tearing up the U.S. with this book and the work that you're doing, and I'm thrilled to have you here, Dr. Brogan. Just thrilled.
Thank you so much. Can you hear me? Just
Yeah.
confirming it. Yeah,
Oh, yeah.
great. Wonderful. It's a total pleasure to be here. Thank you for that long and wonderful introduction. I really, every time I hear my bio, I'm like, I really need to summarize that into one sentence because
I usually do, but I couldn't hold myself back, Dr. Brogan. I just couldn't.
No, I appreciate it. Thank you.
Much to
Wonderful.
accomplish to skip over.
Well, I don't know. I think it was landed in a very expensive wall in my office, basically, is what I have to show for it. So I, I am very excited to give sort of a bird's eye view of what it is that I've come away from a decade of excavating my conventional training. So I want to just start out for whomever might be listening who isn't familiar with my sort of now notorious path. I am a totally conventional, like dyed-in-the-wool med pusher. I was trained as a conventional psychiatrist, very much believed that perfect health was just one prescription away. I was passionate about what's called psychopharmacology, which is sort of the mastery of, prescribing multiple different prescriptions at one given time to one given patient. I actually am formally specialized at the fellowship level in prescribing to pregnant and breastfeeding women. Believe it or not, that is actually a specialty in conventional psychiatry. It's called reproductive psychiatry. And all of this blood, sweat, and tears, and like I said, $200,000 of debt were basically turned on their head when I was diagnosed with Hashimoto's thyroiditis after my first pregnancy. And it's worth mentioning that I was not raised in a very health-conscious household. I spent the better part of my adult life having literally zero body consciousness, never exercised, ate, McDonald's and candy every single day, had no concept of conscious consumerism, dyed my hair black, took birth control pills, was up basically all night long for 8 years. And I had never even been introduced to concepts like meditation or this level of self-care. I was really a stress junkie, like a classic Manhattan archetype, right? And when I was diagnosed with Hashimoto's, which was on a routine physical after my first pregnancy, this like funny voice came up inside me and essentially said, I don't want to take a prescription for the rest of my life. And it was from that place of real defiance and awareness of what the conventional model had to offer, which was a lifelong, tinkering of a prescription, that I actually chose to see a naturopath for a consultation, which was totally unlike me. I don't even know where I got the idea, frankly. And it was out of that level of desperation that I, really complied with her recommendations. I changed my diet. I took a bunch of supplements. I began to revisit all of my products, and I put into remission what I had only ever been taught in my conventional training was a chronic and potentially even debilitating autoimmune condition. And so this raised a number of flags for me. And as is the case, you'll hear from so many holistic practitioners who've really gone rogue. We do so because we have a personal experience of, looking behind the curtain at, in Oz, right? And so it was from my personal experience that I began to have the strength, courage, and really almost, obsessive will to turn over all of the stones, in my own training. And so that's where we'll begin. So as I mentioned, I believe very passionately in the biochemical model of mental illness. I worked a suicide hotline in college at MIT, where suicide is actually a pretty significant issue. And I was supervised by a psychiatrist. I was studying neuroscience mostly because it's the easiest major at MIT, and that's when I decided to give myself a break doing that. But I was really left with this illusion that we've cracked the code of human suffering, and it was just a matter of getting more and more people access to the right kinds of medication treatment. So when I was diagnosed with Hashimoto's and put this illness into remission, I was given a book. And we're going to talk about that book because it changed my life, totally changed my practice. And this book addresses these statistics, right? So we have more and more people on antidepressant medications, but actually psychiatric medication now than ever before, right? But we also have more and more mental health disability, right? Depression is the #1 cause of disability according to the WHO worldwide. And so, you know, a simple question that Robert Whitaker asks is, if more and more people are medicated, why is it that more and more people are disabled, right? Shouldn't those be inversely proportionate, where we have more people treated who are then less disabled, right? If we have more access to treatment, shouldn't we have a lesser burden on a global scale of this kind of illness? And so that's a pretty provocative statement, because the insinuation that he then goes on to support with a number of non-industry funded studies is that the medications themselves are perpetuating disability, right? So the medications that are purporting to treat a given illness, whether it's bipolar disorder, schizophrenia, ADHD, panic attacks, or depression, that the medications purporting to treat those illnesses are actually perpetuating related disability, right? So the treatment is the cause of the problem. That is not a message I would have been able to hear or made any room in my eardrums for had I not had my own experience that, again, began to raise a number of red flags for me around the veracity of what I had learned in my training. And the reason that he is able to call out psychiatry specifically, and there are many more since Robert Whitaker who have come to the fore, including Peter Gauthier, who is the doctor who runs the Nordic Cochrane group. Many of you probably are familiar with the Cochrane database, which is considered to be one of the most legitimate, third-party assessors of available data. Who, he has come out very vocally against psychiatric practice and gold standard practice. And essentially, the claim is that psychiatry is in no way science, right? So we have a situation where psychiatry has become the wastebasket for all of the limitations of conventional medicine, because we do not have any objective tests. So when a patient presents to their internist, which is where the vast majority of psychiatric prescriptions come from, when they present to their internist, they, of course, meet with their internist for 10 minutes. They have a conversation, and their internist, being generally a good person wanting to help, offers the panacea. And the panacea is to take the edge off of whatever it is that they're struggling or suffering with that is of a complexity too great to meet in a 10-minute office visit that is really focused on symptom suppression. And so all of these patients who have complex autoimmune disorders, who have undiagnosed sources of chronic infection, for example, they all get shuttled into the psychiatric mill, because there really is no gatekeeper, right? There's nothing keeping these patients from treatment. And so this is how and why psychiatry ends up collecting all of the patients who are not properly diagnosed, and we'll talk about some of those very obvious situations, or who are treated with other medications, the side effects of which are not acknowledged. And we'll talk about some common situations related to that. Oops. Okay. One of the reigning theories, if not the reigning theory right now, around the etiology of depression, but again, I'm going to use depression as a template, but really we could be having this conversation about any given mental illness label. But one of the reigning theories is that it is caused by a likely heritable chemical imbalance, and that this chemical imbalance is well supported by the literature, and that this is actually the level at which our gold standard therapies are entering. And this is what I was taught to parrot, to the extent that I remember sitting with an attending physician with a patient on an inpatient unit, in my training, and the patient basically said, I'm worried about these, is this antidepressant going to be addictive? Do I have to worry about that? My attending physician literally rolled his eyes and he said, are eyeglasses addictive? So I literally remember this. These are the kind of messages that were, handed down from on high to me as a trainee. And the implication, right, from that snide comment is eyeglasses are a necessary complement to your bodily deficiency, right? The same way that insulin is necessary for a diabetic. So, depression has, in many ways, ridden the wave of this legitimized biological theory. And these are some of the assumptions that, therefore, the interventions are actually the most obvious choice, right? You'd almost be irresponsible to consider anything else. But what I have come upon through my research, and again, I really don't have any original ideas. In most ways, I think of myself as an expert curator. I have done an incredible amount of reading and study. I spend about 4 hours every Saturday and have for 14 years on PubMed.gov, and I look to see what basic science research has to say. And what I have learned has been informed by people, published authors and psychiatrists like Joanna Moncrief and David Healy, who have really poked a lot of holes in this chemical imbalance theory. And one of the most powerful analogies that David Healy uses, he's a psychiatrist out of the UK, is that in many ways, antidepressants are having chemical effects, right? So perhaps we should revisit even the terminology antidepressant and think about the fact that these medications are having chemical effects that are requiring of the body an adaptation. Perhaps that adaptation is something that you like, right? But let's be clear that this is not resolving a chemical imbalance. And the analogy he uses is, what if you had social anxiety and you had 2 shots of vodka? Probably in about an hour, you would say, wow, my symptoms are really abated, that was some powerful treatment you offered me, right? And so if you thought about doing a double-blind randomized placebo-controlled trial of 2 shots of vodka a night versus placebo for 6 weeks, you could sort of theoretically see how at the end of 6 weeks you could come out imagining that vodka is a pretty effective treatment for social anxiety. And we all know, of course, intuitively what would happen if you were to prophylactically recommend that treatment for the duration of, let's say, 10, 20 years, in terms of, let's say 15 years down the road, that patient decides that they want to pursue a different kind of treatment and stops their treatment of vodka daily cold turkey. We know what would happen. And we also wouldn't go so far as to say that the effect of that alcohol is actually meeting an alcohol deficiency, right? It's not correcting an alcohol deficiency, it's having a chemical effect. And so these authors are asking us to begin to look at psychiatric medications in that way, because in 6 decades of basic science research that has spanned everything from analysis of postmortem brains of suicide victims all the way through tryptophan depletion studies, desperately trying to confirm and validate the serotonin theory of depression, there is literally, to my knowledge, not a shred of meaningful, valid science that supports this model. This has all been deductive reasoning. It started with observations about anti-tuberculosis meds and has continued up to the present day, where we assume that these medications work. We assume that they are fixing an underlying imbalance that has to do with these monoamines. And so we are assuming that the monoamine imbalance is at the root of depression. And actually, at this point, most basic science researchers have abandoned the monoamine theory, and we'll talk about the direction that they're going in. So perhaps the first question that we have to ask is depression a disease, right? I think many people assume it is, that we probably have identified that it has a heritable underpinning. So my uncle's uncle had it, and my brother's cousin had it, and I have 2 suicides in my family, so I am at risk. But for that to be the case, we would have had to have some degree of insight into any sort of valid genetic marker, which, after much taxpayer money and many years of investigation has not come to fruition. We would have to understand that it has a discrete and replicable etiology, which, as I just mentioned, is not the case. Very importantly, we would have to understand its natural history. So in the 50s and 60s, Whitaker talks about how we used to watch depression, right, before intervening pharmacologically. And we used to see that in more than 80% of cases, it would spontaneously remit within a year, and often within 6 months. So that the natural course of what we used to call depression was a single episode spontaneously remitting experience that we now have turned into a chronic and recidivistic debilitating condition that is a lifelong sentence in many ways. And so we also have to begin to understand more about the medications that we are using in order to call it a disease. My assertion is that depression is actually a symptom. It's a totally nonspecific term for an umbrella network of symptoms really constituting more of a syndrome that has many, many different, I believe, all reversible sources and causes. And that's what to talk about. So from this perspective, as I mentioned, we're going to begin to think about this treatment model as being drug-based. And when we talk about measures of efficacy, when it comes to conventional drugs, it has to be seen through the lens of these drugs having drug-based effects. So we have to really, according to basic science, abandon the concept that these drugs are actually creating a state of greater balance, rather than the fact that they're creating a new normal, which could explain some of the challenges that we see with this category of medications. All right, so in summary, and this could be a 3-hour webinar in and of itself, but I have a lot of this data and links on my website and in the book, and this information is really readily available if you're interested in the NCBI references. But in summary, we don't have mechanistic support for the chemical imbalance theory, and provocatively, we have a significant and powerful body of literature, largely cultivated through Irving Kirsch, but others have replicated this as well, that suggests that what we are calling medication efficacy is actually mostly related to the power of placebo. Now, when I was in my conventional training, I understood that placebo was actually like a nuisance, right? Like something annoying we had to get out of the way in order to see what the real treatment was showing. And the truth is that anyone who has followed the placebo literature, the truth is that placebo is probably the single most potent driver of outcomes in all of medicine. And that ranges from surgery to pain medication to psychiatric medication. That placebo, and specifically the active placebo effect, which is buoyed and amplified by direct-to-consumer advertising, right? So that consumers are learning about their biochemistry from industry that seeks to profit from them. And when they are enrolled in a trial and they begin to have all of those side effects that they were warned about, what happens? This entire healing cascade unfolds wherein the volunteer or the subject or the patient is essentially messaging themselves around advertisement. They're messaging themselves and saying, oh, that dry mouth and headache and constipation I have right now is evidence that I am taking the treatment and my chemical imbalance is being fixed, just like I saw on that Zoloft commercial, right? So this is what he calls the active placebo effect. And through his research and unearthing of unpublished data through the Freedom of Information Act, he basically demonstrated that the medication's effect does not meaningfully separate from placebo. And that if you compare these medications to medications like atropine with the same side effect profile, you'd be shocked to learn that they have zero efficacy, zero separation. So this is a tough one to contend with, because every time I speak, there's someone in the audience who says, I don't care what you say, you know, my life was saved by Prozac, or my aunt is only alive because of Zoloft, and I won't take that away from anyone. But I will, you know, sort of lead us back to the science, which suggests that the reason that that is the outcome has very little to do with the specific mechanism of the drug. So we also need to bear in mind that in psychiatry, there is this very special significance to unpublished literature, to the extent that actually most of the literature that exists in totality is a combination of evidence for inefficacy in addition to evidence of efficacy, right? So there is a famous study by Turner et al. Out of the New England Journal of Medicine that essentially showed that the same number of positive and negative studies resulted in publication of almost the entirety, save for one, of the positive trials, right? So that's not surprising. But then of the negative trials, not only were 22 of them unpublished, right, of 37, but there were actually a number, 11 of them, that were published as positive trials. So this is a major issue in psychiatry specifically, but actually across disciplines in medicine, where for FDA approval, you only, as a drug company, need 2 studies. And you can do as many studies as you want to come up with those 2 positive studies. But something like flipping a coin as many times as you want to say that you got heads twice. And it's just something to bear in mind when we consider how it is that we have this impression that these medications are, in fact, effective. A very important consideration that, again, is a whole lecture in and of itself is one of the more shocking categories of concern that I have become really focused on, even since the publication of my book, as I've been contacted by more and more grassroots activists, which is this Russian roulette of risk around impulsivity and specifically impulsive violence. And this, you know, I was told in my training to explain this away, you know, increased risks of suicide, increased risk of impulsive violence like homicide, including mass violence in, you know, sort of public settings. I was told to explain this away by saying that, you know, when people start taking a medication, they feel more energized and they end up acting on a previously existing impulse. That's literally what I was told to parrot. And unfortunately, you know, for those passing down that message, the extant literature suggests something different, which is that in largely totally healthy people prescribe these medications for run-of-the-mill issues like a dog dying or stress at work, so not for major mental illness, that we have literally blood on pharma's hands in the form of published cases that show time and again that these largely normal people go on to commit very heinous acts of violence, including, you know, jumping in front of trains, murdering their spouses. And I had, you know, the privilege actually to meet with and co-present with a gentleman by the name of David Carmichael, who was one of these published cases when I was in London, and he spoke chillingly about his experience being started on Paxil for work-related stress, and 3 weeks later he strangled his 11-year-old son to death. And he talked about how it was that he came to this conclusion that he needed to do that, and all the while his affect was such that everyone around him thought he was getting better. So this, to me, is why not a single prescription for psychotropic medication should be written ever again until we are able to responsibly risk stratify around these medications. And what I mean by that is that we have a good sense for the fact that 2D6 polymorphisms are playing a role in the autointoxication around you know, early medication dosing or medication dose changes. And I don't know a single clinician out there who is screening before prescribing for psychotropics, who is screening for 2D6 polymorphisms. So, you know, this is a deal breaker for me from my perspective, and I feel very passionately about the victims who are, you know, showcased on websites like SSRI Stories, Murder Meds, Risk.org, and Mad in America. And I would say, you know, the other categories that have given me great pause are issues that I also didn't learn about in my training. One was that after I read that book by Robert Whitaker, you know, I offered all my patients the opportunity to come off their medication, and man, was that a rough patch in my career, because I was essentially running an outpatient rehab. I mean, my patients were so sick and disabled, I was filling out medical disability forms every single day, and it helped me to understand that these chemicals are really the most habit-forming on the planet, because I have never heard of alcohol, OxyContin, crack cocaine, or heroin needing to be detoxed by 1% or less of the total daily dose per month over years. That is sometimes what is necessary to prevent a disabling withdrawal effect in these medications. And, you know, I certainly wasn't ever consenting any of my patients on that. So, all right. So that sort of leaves us with a dark picture, right? And hopefully I haven't lost anyone with all of that depressing information. When I said enough is enough, I'm putting down my prescription pad, I had to come up with a different approach, right? And I had thankfully already had the experience of self-healing through naturopathic principles. Those of you who are trained in functional medicine or naturopathy are not going to be surprised by the contents of this slide. Why? Because all of these different contributors are the same contributors to all of the diseases of modern civilization. So my effort is really just to bring things like depression, anxiety, bipolar, schizophrenia under the umbrella of evolutionary mismatch. And the name over the past 20 years, so this is not even that new, but we know from the literature that it takes about 17 years for primary science to get into the hands of practicing clinicians. So the name for this is psychoneuroimmunology. And Candace Pert, if anyone knows of her work, and I realize that not many do, she's one of the pioneering women in a sea of male scientists who in many ways began to establish the boundary decimating science around the connectedness between things like the immune system, the gut, and the brain. And she says, in the beginning of my work, I correctly presumed that emotions were in the head or the brain, right? So that's what I was taught. Now I would say they are really in the body as well. They're expressed in the body and are part of the body, and I can no longer make a strong distinction between the brain and the body. And this is because she was the discoverer of the opiate receptor and went on to elucidate the role of neuropeptides as they traffic throughout all of the systems of the body. And in many ways, this has helped me to understand how and why it is that some of the ancient technologies that I employ that we'll talk about have the effects that they do. Okay, so I mentioned this term evolutionary mismatch, and essentially what this refers to is the fact that over several million years, we've had fairly consistent exposures and co-evolution with our environment, botanical environment, microbial environment, and that in the past 10,000 years since the agricultural revolution, but maybe more specifically in the past 150 years since the Industrial Revolution, our exposures have changed from top to bottom to the extent that we are no longer having the human experience we are designed for. And I think many of us intuit this, right? If we can really get serious about this, you know, we'll admit to ourselves that something is gravely wrong with the way we are approaching the human experience today. And one of my favorite books on this subject is by Jane Liedloff. She wrote a book called The Continuum Concept. And essentially, she talks about the very principal tenets of the human experience beginning from pregnancy, childbirth, and in-arms infant care for 6 months. And she basically argues that, you know, you can deviate from that all you want, but your nervous system and your body mind are going to be screaming for the duration of your experience, right? And that scream can take the form of all manner of addictions, you know, mental illness and associated struggles, all the way to physical illness, but you have to come back. And so a lot of what I do with patients is to bring them back to that continuum. It's very simple, powerful medicine to begin to send the body the types of signals it longs for. And it really ends up being quite elegant, I think. So when I began to follow the literature on psychoneuroimmunology and the inflammatory model of depression, it was a bit overwhelming, right? Because we have all of these different sources of inflammation, like where does somebody enter? How do I know what to focus on? And this is where, the literature on the gut-brain connection really becomes relevant. It sounds like there was a very recent webinar on that, so I can imagine that some of this is already familiar. But some of the early rodent research essentially showed that, there can be significant derailment of the stress response and in germ-free rodents, right? And that with replacement of Bifidobacter, it's just a very simple experiment, with replacement of Bifidobacter, that stress response curve can be totally corrected. So what that tells me is that the microbiota is actually a very chief influence in the sort of tenor of the rest of our systems, whether it's the immune system, the hormonal system, or brain functionality and messaging. And so I think it's very intuitive for most of us that the brain influences the gut. Anyone who's ever had butterflies before a presentation or diarrhea before a first date or something like that, has this, appreciation. But the bidirectionality or the influence of the gut itself on the brain has just begun to be elucidated, and we have most of the data around depression focuses on using LPS, or lipopolysaccharide, a component of gram-negative bacteria, in the induction of depression. And this is how we've begun to understand that when the gut goes wrong, the brain actually reacts purposefully to coordinate behaviors for reparation and regeneration. And that in many ways you could look at these symptoms and associated behaviors as being a problem, right? The problem of depression. How do we get it gone? But again, I would love to reframe it as a built-in sort of signal, a built-in messaging to call us back to these very, sort of basic relatedness to the environment. All right, so on a macro level, I am very interested in these discrete causes, all of which can have relationship directly to inflammation as a messenger, all of which relate specifically to dietary intake, which we'll focus on really for the remainder. So some of what I call the psychiatric pretenders, or the things to really bear in mind when you have a patient who is presenting with symptoms of depression or anxiety, or I would expand that to say ADHD or chronic fatigue, or even a history of mania or panic attacks or OCD, that I look at these, and I wouldn't exclude schizophrenia. The gluten data on schizophrenia is really quite powerful. But I would look at these things. So blood sugar instability or dysglycemia is a major, major driver of inattention, of anxiety and insomnia. And this is literally, resolvable in 2 weeks on a high natural fat diet. I think many of us are getting that message, but remember it when we're thinking about psychiatric pathology. Don't forget about that. I have been following and very interested in a literature on the role of gliadin in mental illness, and now we have crossover trials looking at exposure to gluten versus a rice placebo inducing symptoms of depression in a matter of days. We have a recent case right up in New England Journal of a 37-year-old who literally was so delusional and psychotic that her family took out a restraining order and she became homeless before they diagnosed her with celiac disease and Hashimoto's, put her on a gluten-free diet, and she was symptom-free within 2 months. So this is not just about a fad for weight loss, right? So elimination of processed foods and gluten is really, no pun intended, a no-brainer when it comes to psychiatric pathology, because it can be that dramatic. Medication specifically has been a major concern. I talk a lot about that in A Mind of Your Own and on my website. I talk about, things like proton pump inhibitors. I don't know why it only has that, but proton pump inhibitors, birth control, antibiotics, Tylenol, NSAIDs, vaccines, where I have delved into the literature again, because remember, I was told that these medications are safe and effective. When I scratched the surface of the literature, I found a very different story. And all of these medications can have direct effects on mood, cognition, and behavior. You know, there was a recent study out looking at the role of Tylenol in emotional numbing. Whoever thinks about that, you know, when you have some cramps or something like that. So then there are some sort of downstream effects, so things like birth control impacting sex hormone binding globulin or thyroid hormone binding globulin, interfering with free hormones, for example, even though on paper, if you're not checking for those binding globulins, everything looks fine, all the way to proton pump inhibitors that are influencing B12 absorption, generating B12 deficiency, which again has been documented in the literature to cause everything from you know, amnesia to psychotic depression. So these single nutrient deficiencies can be very significant. And then, of course, I think it's no coincidence that I developed thyroid autoimmunity as perhaps a means for me to better appreciate the potential role of the thyroid, and specifically autoimmune thyroid diseases like postpartum thyroiditis and Graves, in all manner of psychiatric pathology, from postpartum psychosis to suicidal depression. So I am very passionate about at least screening for, although the interventions are never really that different, but at least screening for the role of autoimmunity to interfere with the prescribing of an antidepressant, because it would make no sense, obviously, to take Zoloft for a thyroid condition. You know, that would be like taking Tylenol for a piece of glass in your foot. It doesn't really make any sense when you sort of think about it from that perspective. So, okay. And I mentioned these were some of the medications to sort of bear in mind. And I have a peer-reviewed indexed paper on the role, I called it the psychobiology of vaccination, of the specific role of vaccination on brain-based inflammation. And the rest of these, my literature is culled really from the past 5 years of PubMed research. So birth control, many of you may know, that there was just a 1 million-person study that came out following women for 13 years, looking at increased rates of treatment with an antidepressant with birth control versus non-birth control treatment. And in teens, that was up to an 80% increase in antidepressant treatment. So this literature only continues to expand. All right. So what do I do with patients? This is the fun part. We've arrived here. Okay, so I am an activist at heart. Fundamentally, I wake up every day because I feel passionately that we are ready for a new conversation around health, specifically around women's health. And of course, it's, you know, seemingly poetic that I have found myself specialized in literally a discipline that in its etymology, because it has now become the nature of my practice not only to resolve symptoms, you know, so if a patient comes to me with brain fog and some constipation and insomnia, I'm interested in resolving those symptoms, but I am far more passionate about inducing a transformation. And the nature of this kind of transformation that is possible through self-healing is really cosmic in nature. I mean, the sky is the limit, and often it can look a bit ugly for a period of time. You know, I have probably a 90% divorce rate. I've recently tabulated from beginning of treatment to end of treatment with me, and part of that has to do with coming into greater alignment with one's own power, and how that forces us to look at the many constructs that have been buffering an old self. So the work of coming off of medication is not for the faint of heart, but you know, and your patients know if they are ready, and they will not stop until they find the right support. So for any of the clinicians out there who are feeling inclined to support this kind of work, it is the most rewarding, most gratifying thing I could imagine doing with my life. And so I've spent the past 10 years developing a protocol to make it easier. And you'll find that it's really not that complicated, but it does require a degree of commitment, quite a high degree of commitment actually, because this is serious, it's a serious stuff. And coming off of psych meds is not for the faint of heart, but it can be mitigated and can be simplified. So when I began to understand that this information was not readily available, of course I began blogging, and then I decided to write a book to put it out there. And just to sort of, bring to awareness how readily applicable this information is, this was an email we got, at the office shortly after the book came out. And she says, I wanted to take a moment to submit to your evidence bank more data regarding the efficacy of your dietary lifestyle recommendations. She says, let me preface this by saying I was diagnosed bipolar in 2001 after the first and last manic episode I experienced. While the DSM is the DSM, I have long believed I am not bipolar, but in fact experienced a spiritual crisis and have fairly concrete evidence that I have been managing early stages of a Kundalini rising with intermittent dark nights. Okay, so in my former incarnation, I would have, found this missive basically grounds for antipsychotic prescription for this woman. I would have had no idea what the hell she was talking about and would have been very concerned about her consciousness. Obviously, she's speaking to somebody who now understands this language. But interestingly, that aside, her characterization aside, how many of these symptoms, could, I would say, like the vast majority of patients be struggling with that could be improved within a couple of weeks. She said that in following the dietary protocol, she had these changes in 2 weeks. I don't know a single medication that's capable of this. And so that's what gave me sort of like the early win, the early sense that this was something that could be replicated on a large scale and that people are ready for this kind of self-healing, as I think many of you already know. So I want to touch on some of the things that I recommend beyond diet before we get into that. I followed the literature on mindfulness-based meditation for several years, mostly out of the Benson Institute. 40 years of literature look at mindfulness-based meditation can change your gene expression, with basically just listening to a guided meditation. I tried it. I could never commit to it myself, and that was not for lack of faith in it. I have become a total zealot about Kundalini yoga, and specifically Kundalini yoga meditation. I'm now a certified instructor. And the reason is because it's very busy. So in an average Kundalini yoga meditation, there is a specific breath. You have to look a specific place. Sometimes you're moving your arms in a specific repetitive way. You have to sit in a certain way. There is a lot going on that has its own specific effect. So from many perspectives, Kundalini is one of the oldest forms of yoga that recruits all of these different modalities, from mudra to pranayama to asana, mental focus, and that it's because of that that it is considered the yoga of consciousness transformation. And I have, not only had this experience myself, but then I've gone through the literature to find that there is actually some pretty shocking, like a 71% rate from OCD symptoms. There is not a medication on the planet that could boast that outcome from a specific protocol by David Shanahoff-Khalsa. And, there is science to support it, but moreover, it's an experience that's worth having. So I ask my patients to commit to 3 minutes a day. You can go on the internet and you can Google Kundalini Yoga meditation, digestion, or stress, or PMS, or intuition, and there are thousands of these. Almost all of them are available for free online, and you can adapt them down to 3 minutes for a specific effect. So I ask patients to commit to 3 minutes a day because I believe that is a very doable piece of time. 5 minutes may be even too long, but 3 minutes is totally doable. Even sometimes I think the ritual of doing it, forget about what you're even doing in the 3 minutes, may even be having more of an effect. Okay. I will spend a couple of minutes now, okay, we have time still, talking about the diet. Nothing about this diet is going to be that shocking. Other than that, it is a red meat inclusive diet. So again, this could be a lecture in and of itself, but suffice it to say that as a former ethical vegetarian, I was pretty appalled to learn that my healing reached a ceiling before the inclusion of red meat specifically in my diet, so meaning like beef, bison, lamb, or pork, for example, actually is included in the red meat category in this rubric. And I have found that in my own clinical practice that my work with vegans and vegetarians is psychospiritual period of time before we can begin to consider whether it's worth a trial of this template. My work and clinical outcomes over several years were then supported by my experience with my now late mentor, Dr. Nicholas Gonzalez, who basically characterized the vast majority of the patients I work with as what are called parasympathetic dominants, who will only ever get well with the inclusion of red meat in their diet. And this can be up to 2 times daily, okay? So it is a red meat inclusive diet, mostly for my templated 3 to 5 times a week. Vegetables are included, including resistant starches like sweet potatoes, but the first month, white potatoes and grains are limited. All of these, what are called microbiota accessible carbs, are limited so that we can very deliberately include them later after the 30 days and monitor for effect. So these are the included foods, the excluded foods. The alcohol and coffee bit is very challenging for a lot of the New Yorkers that I treat, but it is so imperative that you take 1 month of your adult life and understand specifically what the effects of coffee, for example, or alcohol are on your body when you reintroduce them, if you choose to. You know, I gave up coffee 8 years ago and I never touched it again. And I used to think I was a tired, irritable person, and now I understand that it was just coffee. Of course, I was drinking 6 cups a day, but you know, you deserve to know what it is that your relationship consists of with these different kinds of potentially addictive foods. I encourage the use of what I call therapeutic foods. The first month of my at all. And so we use these kinds of foods like collagen or gelatin, which is essentially like a powdered bone broth. We use organic grass-fed liver, or you can eat it, of course. I had a lot of trouble, and continue to be honest, incorporating liver into my diet. Coconut oil, ghee, and turmeric are foods that I have patients, you know, put turmeric in your scrambled eggs. I have a smoothie recipe that's very popular on my website and a video for it that includes a lot of these natural fats and ends up being a very good antidote for a lot of the blood sugar instability that my patients struggle with. After the 30 days, we do introduce these foods. So white rice, white potatoes, beans, and gluten-free grains. The vast, vast majority of my patients live with these foods in their diets after 30 days. So it is not a low-carb diet long-term. It is not a classical paleo diet long-term. This is Nick Gonzalez's template for what the diet then looks like. And it's sort of the amounts that I sort of mentioned. And fruit is included, so are honey, maple syrup, naturally sweet, you know, sweeteners that exist that way in nature, so to speak. And then I'll just make a quick mention that I do not do any medication tapers before the 30 days. So my patients take their regular 5, sometimes 10 psych meds the whole time. And we often can still see and feel a clearing of a lot of their physical symptoms. And the idea is to cultivate optimal physical resiliency before we begin the taper. And the details of the taper process are a bit beyond the scope of this, but suffice it to say that this does not start during the month. The last thing that I have become very passionate about, I learned from my mentor, Nick Gonzalez, which is coffee enemas. I'll just read this hilarious commentary from one of the participants in the online program companion to the book called Vital Mind Reset. And this was from the beta launch. And she says, okay, so coffee enemas. I tried them for the first time today, and I have to admit that I'm sold. I'm not sure why I ever bothered drinking this stuff when this is possible. She says it wasn't nearly as complicated as I thought, and things went pretty smoothly, and I actually noticed an immediate decrease in some of my symptoms. I was concerned about the caffeine because I've been experiencing higher than normal anxiety, and I didn't want it to make me jittery. However, I actually feel calmer now than before I did it, even though my energy level is a bit up. I wish I hadn't put this off for so long. And I would say that this has been the universal experience of every single patient I have encouraged to do a coffee enema. The coffee enemas that I recommend are primarily in the setting of significant bowel disease and or, meaning gut dysfunction and or medications or medication taper. It has been a total game changer for me, and most of my patients have this experience and then become evangelists themselves. The instructions for the coffee enemas are handed down to me by Nick Gonzalez and are in the course and in my book. So that brings us to the end, and I will just say that I have become totally inspired by the potential for people to take this information on their own and engage in self-healing. The component that I feel is surprisingly powerful is even embodied by this experience we're having right now, which is that Vital Mind Reset, which is this online program I recently launched, has a Facebook group, right, like a private Facebook group associated with it. And so a community has been born around support for this kind of healing. And I do believe that in future models of this kind of holistic healthcare, that kind of community will become more and more essential to the amplification of real results and meaningful transformation. So it's really been inspirational for me. So thank you so much for the time. I know I've gone over a bit, so I'm not sure if there are any questions.
Oh, there's a few, Dr. Brogan.
Great.
There are a few, yes. Thank you so much. First, I want to just express my extreme gratitude for you moving from a drug pusher into an enlightened state and,
Well, I'm not
the
sure
work that you're doing right now. What a difference, right? I mean, I can't imagine how different you feel when you wake up in the morning and at the end of your work week from what you were doing of just writing disability notices and so many things and all the prescriptions to this.
No, I have the best job in the world. I really do. I really do. I really feel a deep gratitude for that, actually.
Yeah, well, okay. Well, a couple things. Just a point that you made about the person who said that are eyeglasses addictive. It really stood out because I think mine are. I mean, just my answer to eyeglasses is like, yes, anything that we do repeatedly.
Right, you can even pick that one apart. It's so true.
Right. I mean, I've had the experience of wearing my eyeglasses and saying, where are my glasses? It's like, it's bad enough when it's on your head, But when you're wearing them and you say that, it's like, yes.
I don't think he had that insight. I think he was trying to be dismissive. But of course, we know people who literally reverse their myopia, through natural means. But I don't think he had that degree of insight. I think he was just trying to shut down the conversation,
Exactly. All right. Well, I'm going to go to your book because there you mentioned that you've yet to meet a woman who can do a low carb diet long term, and clearly the protocol around food that you just showed isn't low carb. Correct. Specific carbs reduced for a period of time. So can you elaborate just on that for a bit of your take on low carb diet and what's happening with the women that are doing the ketogenics and versus the low carb, etc.?
Yes. So listen, the nutrition wars are alive and well, and I really try my best to avoid dogmatic perspectives. And so even that statement probably is overly dogmatic. And the truth is that, the truth is I'm sure there are women who are feeling wonderfully on a ketogenic diet. My own personal experience was that I toyed around with an extreme paleo diet that, in my opinion, is really more designed for a male physiology. And I felt great for 2 months. And then I began to crash. I began to lose hair. I began to feel tired. I began to have swelling in my ankles. This was years ago. And so I intuitively began to reincorporate gluten-free grains, and I felt better. And this has been my experience over and over again with patients to now, now I'm at the point where I just come right out and be clear that this is not a low-carb diet. But then when I worked with Nick, Nick was putting into remission, long-term remission, metastatic cancers, including brain cancer. And he never once used a ketogenic diet. So that was also reinforcing to me. And what I began to understand in the female population specifically was really predicated on the modern hunter-gatherer literature, even looking at the Hadza, for example, out of Tanzania, where the women eat honey and tubers and they eat more quote-unquote carbs than the men do. They have a different diet than the men. And perhaps this has to do with thyroid physiology. There's some, sort of thinking and really, sort of like theoretical, exploration of the fact that you could potentially induce thyroid slowing with too low a carb diet or too abruptly low carb diet, where your body basically then begins to perceive that it's time to hibernate, so to speak, and functionally put the brakes on your thyroid. So, there's some theories, but the truth is that most people just feel better, with I would say a moderate carb diet, although I really hate thinking about diets in terms of macronutrients because it begins to undercut the truth, which is that we're working with food as information and it's not about its component parts.
Right. And it's going to come down to the individual. I mean, do you see that right? You see commonality across your practice, but individuals are going to react to different foods and may need a longer time off grains or need different vegetables than others.
No question. And the reason I feel so passionately about eliminating addictive foods, the basic stuff, coffee, sugar, alcohol, increasing hydration. So really, for the first month, I ask my patients to only drink water, filtered water, is so that we can have a stronger signal of your real preferences, right? Yeah. Because once you peel back those addictive foods, then you can be able to hear what it is that you actually want to eat. Do you feel like eating meat every day? Do you feel like eating salads every day? You're going to begin to personalize it yourself, because in my opinion, there is not a test on the market, despite many being offered, that can really help you decide what is the best diet for you. You are the one who knows. So we have to clear the signal, yeah.
Clearing the signal, it's a great term, thank you.
Yeah.
So sticking with thyroid a little bit, you also, do you recommend that your patients start with a thyroid test? Is it the first thing that you check?
It's a good question. In my practice, I do a battery of blood work that is all, nothing too unusual, but that's all written out in the book. And I do it in the beginning, mostly for me, mostly because I like to see the changes on paper. But the truth is my interventions are the same. And in the course, we have beta tested not doing any blood work on any of these any of these participants. And you know what? The outcomes in the course are even more robust than in my practice. So, meaning they're faster and more dramatic. And so I'm not sure how necessary the testing is. It's a good question. I think if you haven't gotten the results you were looking for in the first month, then it's definitely worth doing the testing, because let's say you have a ton of thyroid damage and you could benefit from a natural hormone replacement, that would be really good to know. So you don't end up, persisting in that vein too long. But I still think it's a valuable thing to have the month even without the testing.
Do you see a real prevalence in thyroid imbalance?
Oh, incredibly. Because I test everyone, and I test for autoantibodies, I test for thyroid receptor immunoglobulin, I test for thyroglobulin and thyroid peroxidase. I look at those three in every patient. I would say, if I had to guess, it probably like 80% of my patients have some autoimmune activity, even if their hormone levels are functionally normal. And in psychiatry, we actually have some literature suggesting that even with autoimmune activity in the thyroid, whether or not the thyroid hormones are normal, there is still a significant quote-unquote risk for things like a diagnosis of depression. So it's meaningful to know. But again, it doesn't change my initial interventions that significantly.
In my practice, I recognize the importance of thyroid testing, but it usually goes hand in hand with adrenals. Usually there's a significant stress, adrenals are weak, and these two glands work together. What's your thoughts on that?
Yes, and that actually is a big part of Nick Gonzalez's approach and theory, is that the stress response is at the root of all of these derailments, and how the derailment manifests, whether it's in a solid tumor like a breast cancer or a liquid tumor like a leukemia, depends on your autonomic dominance. But most of my patients, if they do take supplements, do take adrenal glandulars, and I, again, learned about that from him. And but I also feel very passionately about the potential for something like meditation, or specifically Kundalini yoga, to make a ton of progress, if not the lion's share of the progress, in healing that stress response from the top down. So there, as we all know, there are so many ways to enter the conversation about stress response, from mind-based practices to gut-based practices, to cleaning up your cosmetics.
Yes.
So if you do all of those things at once, you're really sending yourself a different signal.
Yes, quite. Thank you for that. I want to bring you back to tapering a little bit.
Yeah.
It doesn't seem like doctors are medically trained in it.
Yes, that's correct.
So is there any research on tapering?
Research is actually underway. It's grassroots research. Mad in America has written about it, and it is underway. MadInAmerica.com is Robert Whitaker's platform. It's an incredible resource I couldn't recommend enough, just for ongoing blogging, and also collection of resources around withdrawal support. But the truth is that this is an unacknowledged risk of modern psychotropics. It just hit the literature itself in terms of being identified as withdrawal, and sometimes protracted withdrawal, rather than what we were taught in training up until my training, which was not that long ago, was a relapse, right? So patient comes off meds, they totally hit the roof, and you say, oh, you see, you should have continued your meds. Look how sick you are, right? And now we know that the basic science is not reflecting that this is actually a complex withdrawal phenomenon, and patients can be totally debilitated, literally physically debilitated by these taper processes. So that's why I feel very passionately about beginning with these steps first, before beginning taper. I learned everything I know about tapers from patients. I never had anyone teach me. I never had a resource I could turn to. For actually several years, I learned the hard way about having to go 10% of the dose per month, how to use compounding pharmacy, how to begin to engage the dance with the patient, because every single case is different. And you don't want to go too fast, but you also don't want to create a 5 to 10 year taper out of something that could have been done in 6 months. So it becomes a project and a process of learning. And while a lot of the information on the internet is focused on the physiology of it and the metrics of what percentage to come down per month, I've actually come to believe that a lot of it is mindset. So when you're ready and you've acknowledged that this is a journey that you're about to go on, and your entire life might change, literally, who you're married to, what you're doing for a living, whether you want to have kids or don't, where you live, your relationships with your family members, that all of this is up for reexamination and potential shedding. If you're ready for that, then it's probably going to be a really successful taper. And if you're afraid and you just think you need to come off meds because you're not happy with them, but you're just totally scared of the process and you don't know what you're going to do without them, it's not going to be pretty. So I do believe that there is a psychospiritual component to this that otherwise complicates or reducing it to a simple protocol.
Well, in the detox summit, you certainly talked about your protocol, and I'm wondering how you arrived at that. Just a general protocol, so it's following the lead of your patients and collating this over time and coming to something that in general you can apply.
Yeah, so the very general protocol, I also, by popular demand, have an entire module on it in Vital Mind Reset. It was a little bit smaller section in the book, but the general protocol is that I come down by a test dose first. So it's about 20 to 25% of the total daily dose, and we come down by that amount and see how the patient does. So often I use amino acids in this setting, complementary to the understood mechanism, but I also use, meaning like 5-HTP or tryptophan for an SSRI, or mucuna pruriens or tyrosine for Wellbutrin, for example, or a stimulant, and then I'll use a broad-based amino acid mix as well. And so in that setting, I'll come down by 25%, see how that patient does for about 3 weeks or so. If that's fine, we may even go at that increment per month. I usually do month intervals, and we just see how it goes. And if that is problematic, like they develop insomnia or agitation or strange physical symptoms. A lot of gut symptoms can emerge, a lot of, sort of rebound autoimmune symptoms like
Yes.
psoriasis, for example. Crazy stuff can happen. So if that happens, then we know we have to operate at 10% or less.
You just slow it down.
Yeah, you slow down the increment. And compounding pharmacies, I work with Johnson Compounding and Wellness, love them, have had amazing experiences with them over many years, and they've helped me tremendously customize pretty much anything and everything for my patients, literally down to 1/1000th of a milligram per month for some of my patients. It's really, you wouldn't believe it unless you saw it. It's just really wild.
I appreciate that too, because I work with a very good compounding pharmacy, Dollar Drugs, out of Santa Rosa, and very similar. Just tremendous quality, great attention to detail. Are willing to show up and
Yes.
supply what's needed, and they understand it.
It's a gift, yeah, to have that kind of resource.
Sure. So I'm glad to hear you speak to amino acids, because in the beginning you talked about the no serotonin deficiency theory.
Yeah.
And so certainly Trudy Scott, I know you're familiar with Trudy Scott
Yes.
and her summits and the work that she's been doing with neurotransmitters and amino acids. And so speak to that just a little bit, because there is no serotonin deficiency, but serotonin and GABA seem to play a big significant role here. And so yeah, your thoughts are appreciated.
Yeah. Oh my God, I decided to make myself a cayenne tea right before this webinar. Sorry, I'm making myself cough. Yeah, Trudy and I love Trudy and very much respect her. She is just really a guiding light and a wonderful human. We sort of agree to disagree on this front, and we've had, sort of open conversation about it. And the truth is, if it's working for you and it is safe and natural, meaning that your body actually recognizes the molecules that you're working with, go for it. I have no criticisms. This is absolutely not, sort of a turf war. I do think, though, that a lot of natural medicine has sort of potentially taken a page out of the pharmaceutical handbook in assuming that there is a discrete role for serotonin in mood, because I have looked at the literature and I am totally unconvinced. But I am not alone. Joanna Moncrief talks about this, David Healy, Leo Lacasse. There are researchers who've been talking about the fact that if you look at the literature, it's just not there. So what does serotonin do? Well, a lot. Actually, some of the more modern theory is that it is a neurotransmitter that actually allocates resources when the body is under duress. So do we have any understanding of how and why 5-HTP or tryptophan might be helpful? No. Could it be helpful independent of our theories? Sure. It just happens to be my orientation not to reduce depression to a chemical or a nutrient imbalance in any case. I mean, even if I see a B12 of 100, I still want to do a whole lot of other stuff. I still want to do a total nutrition overhaul. I still want my patients meditating. I still want to do, a product detox. I'm never going to just recommend B12 injections. It's just not my approach. And not that that's anyone else's either, but to use sort of like the magic pill, whether it's natural or otherwise, just isn't generally my approach, because I'm going, it's sort of like a go big or go home model. Like I am going for major gains here. I'm not just going for feeling a little bit better. I'm taking this opportunity to reconfigure, entire lifescapes. And, that's what I'm in it for. So I tend to not use supplements in that way, even though I spent many years, following the research on things like SAMe or rhodiola, turmeric, specifically curcumin. I know this literature, and I support its use, absolutely. But it's not my primary point of intervention at this point.
Okay. But it's a piece of your toolkit, right?
Yes, particularly around medication tapers, I have found amino acids to be really invaluable.
Okay. Let's address brain scans a little bit. Do you see any role for them in psychiatry?
It's a good question. Because of, the research I mentioned of Candace Pert's work, for example, I've really come away from thinking about behavior and cognition as being discretely localized in the brain. So while I am interested in brain-based inflammation and I've followed that literature, I am also interested, if not more interested, in the web, right? So the connectivity of entire systems, including fluid systems like hormones and the immune system that traverse all of these different boundaries. I have found that a lot of the brain scan work has been put to the service of selecting the appropriate, so to speak, medication. And of course, that is not my orientation. No. So I tend to, again, find a lot of simplicity and power in all of these different interventions that are really lifestyle-based, put in front of diagnostics. Because I think while diagnostics, even like scanning for, screening for thyroid dysfunction, are very interesting and compelling, they tend to be more so for the clinician than necessary for the patient sometimes. Although I will offer that many patients would respond ritualistically to the placebo effect of testing. I have a whole cohort of patients who come in asking for adrenal tests, asking for salivary cortisol assessments. And I can understand that for them to see it on paper has an effect, and that then their motivation, their will, the crystallization of their understanding is really amplified. And so I don't take that away from anyone, but certainly a brain scan is really a totally benign intervention, and if it's in the service of selecting a medication, it's obviously not something I'm going to get behind.
Yeah, interesting about placebo efficacy, because I just read a study that were even when people knew that it was a placebo, it still worked. They were told that half of them got a higher dose or a lower dose, and those that got the higher dose, knowing that it was a placebo, still said it worked great.
It is quite incredible. When you delve into the placebo literature, your mind literally is blown. I mean, everything from decreased blood loss in surgery to more rapid bone healing, to the opposite, which is the nocebo effect. One of my favorite studies looks at people who are treated to remission on Prozac. So that person in the audience who would say, Prozac saved my life, right? And you tell them that they have the possibility of being randomized to a sugar pill versus continued on their exact same dose of Prozac, and both of the groups actually got clinically depressed. So the one group is taking their very same dose. Exactly. But the simple fear and belief that they could have possibly gotten the sugar pill took away all of the efficacy. How can we say, given that that literature exists, that this medication is having an effect based on its scientific mechanism? It just doesn't make any sense. So the placebo research is fascinating.
But coming back to your work with the mind and meditation is brilliant. It's like, yes, pay attention to what we think.
Exactly. It's sometimes the only thing that you can control. And you can't control it by will, but you can control it through practice. And, for some of us like myself, it takes a while. It's taken me, I would say, about 2 years and a solid commitment to daily practice to really feel like I have gotten somewhere, like my nervous system is a different thing now than it was years ago. But what else can do that? I mean, there's no pill on earth that can do that for you.
Yes, in Dr. Deanna Minnick is running Whole Detox right now, and it's a brilliant piece of work, because one of the parts of it is addressing false and limiting beliefs.
Yes.
And it's just wonderful to see how people work with that and really shift it, from the morning to the night, and how much it can shift and start applying it. So the power of the mind is bravo for
Absolutely.
For you. It just makes me think, when I brought up brain scans, it was because I wonder what the brain of a depressive or an anxious person looks like, or a bipolar, compared to someone who's not, or compared to someone who's using the power of their mind to address things like that, and how it changes while they're doing their meditation. That interests me.
It was really interesting, because I had one of the participants in Vital Mind in the beta group, for whatever reason, was getting EEGs done, right? And she said that I have this screenshot, actually. It's really fascinating. Anyway, to get her EEG done, and she was full of beta waves, And she had just learned, because I teach a 3-minute meditation video for each week, right? And so one of them had this like hands clasped at the heart mudra. And so she said, for whatever reason, while she was getting the EEG done, she did that mudra, and that there were totally visible shifts in her brain waves to alpha waves during the scan, just by positioning her hands in that way. I thought it was the most incredible thing ever, that we have these like ancient programs just longing to be activated, where healing can happen in seconds to minutes. And, it's just a matter of becoming aware that they exist.
And your book is addressed for women, but does it apply to men too?
Yes, I get this question a lot, and the book and a lot of my materials are very pink. I identify very much as a women's advocate and feminist. I see myself as being here to really do whatever I can to be an ambassador to the next story for women. That being said, I have used this protocol on my dad and my brother, and I find that when compared to my colleagues who, treat men in their practices, there's really nothing gender specific about it. The book itself doesn't have any women's rah-rah in it. That's going to be my next book. And it really is a very basic protocol that I actually recommend to friends even who have children or teenagers. So it's really, unfortunately, it's the only book on the market of its type, as far as I know. So it really ends up being a resource that probably should be made available to all genders, all identifications, but it just happens to be what I'm familiar with. So,
okay, all right.
And we do have men in the Vital Mind group.
And another question: if there's any situation where you do recommend medications, or that people linger on their medications beyond the 30-day initial start.
So these days I have a very skewed practice of people coming to me already decided that they want to come off medication. So no one chooses to stay on it in my practice after the first 30 days. In fact, they're like chomping at the bit, to get going with the process. I have really come, I put down my prescription pad in 2010. After I read Anatomy of an Epidemic, I never started a patient on medication again.
Okay. Yes.
And I feel that my orientation around that, and I have suicidal patients, I have psychotic patients, I have actively manic patients, because coming off of these medications can induce all sorts of phenomena. But I am unafraid, I really am, and I feel very comfortable holding a space of curiosity around these experiences, and I know that when you don't resist them, they pass. I have witnessed that time and time and time again, that we create complication and often, a enduring experience out of something that could have come and gone if we just made space for it. I often, really encourage family involvement, so I like spouses to be involved and parents to be involved in my treatment. In fact, that's part of our intake, is to make sure that people are all on the same page and in the same belief system. So my perspective is that there isn't a role for psychiatric medication. I'm not sure how I could justify it when in 30 days with these basic principles we can get total reversals and remissions. I mean, the outcomes that I get, I'm publishing one in a peer-reviewed journal as we speak, who is probably one of the sickest patients I've ever heard of. In all of my training at Bellevue and in all of my private practice experience. And, in 2 months, she's in total remission with these tools, and she had been on every medication under the sun, and nothing helped. So I'm not sure what the justification would be. Even prescribing psychiatrists will tell you need 6 weeks for the medication to quote unquote work. So we're not talking about a quick fix. And if I'm asking for a month, it seems like, why wouldn't we start with the least harm? I have a participant in Vital Mind Reset who is an incredible woman, an incredible transformation case, who did the program on food stamps. This is accessible to everyone, and with the right information and support and motivation and commitment, it is doable. So that is my extreme perspective, but I am not here to tell anyone what to do. And if you are aligned with, a pharmaceutical treatment, then that's probably what you should do. Meaning, like, if you believe that is best for you, it probably is best for you. So I'm really here to represent another option, one that I feel very passionately about, and that I think is really a perfect toolkit for someone who feels that internal yes, that internal affirmation about this possibility.
Exactly. It's right for the person it resonates with.
Exactly right. Yes.
So we have somebody in attendance who's says she's an allopathic physical therapist working on her MS in holistic nutrition, and
Awesome.
asks, do you ever try to practice the ancestral health within the traditional allopathic model using insurance, or did you need to leave the traditional setting altogether? And if you did,
So,
why?
yes, great question. So I actually was trained and practiced in Manhattan. And in Manhattan, even for conventional psychiatry, there is a precedent for out-of-network, sort of, fee-for-service model.
Yeah.
So even, as a pill pusher, I was doing that. And there is just a cultural precedent for an expectation that if you're going to get quote unquote good psychiatric care, whatever that means, that you're going to have to pay out of pocket for it, and actually it's going to be reimbursed with parity, relative to a medical condition, so to speak. So I have never participated with insurance. My fees are actually quite significant, and part of that is simply because I don't think people need to see me. I've come up with these resources because if you have sufficient motivation, you can do this by yourself. You don't need to take the time to see me. I make people fly in from all over the world for in-person appointments. I don't do remote consultations. So it's a big investment. And I really just don't think it's necessary. So I really encourage self-initiation. But that said, there is still a market. Obviously, I have quite a long wait list for people who want that one-on-one care, and it's just not possible to do this in the framework of insurance. And many patients don't want their personal business, broadcast all over insurance documentation. And to have the freedom, my consultation is 2 hours and then an hour follow-up, so it's a 3-hour experience. There is no insurance model that allows for that kind of time and personal attention. So, I will make a plug for my friend James Maskell's new book called The Evolution of Medicine, where he talks about how to transition from conventional to integrative practice. And man, do I wish this book was available when I was making my transition. So there's a lot of support and resources available for someone exactly like you. So I would definitely check that book out.
Thank you. Coming back to the initial lab work that you do you evaluate copper zinc balance?
So I have lectured in Australia, and for whatever reason, I do a ton of podcasts there. There's a lot of interest in this, and I get so many questions about pyrroles and Bill Walsh's work. And
exactly.
Yeah, and I don't. I don't in any of the ways related to his work. And again, that is not to say that it's not helpful for some people. He also believes that the monoamine theory of depression has some relevance. So we're fundamentally not aligned in that way. But again, I'm sure that he has helped many people. So there is no one way to crack this, but I do. I don't. I really don't work with. I really don't even work with orthomolecular dosing of nutrients, and that is not because I don't believe that there is data for that. And it's just less necessary when you commit with a level of zeal, that I expect to these basic principles up front. In my experience, all of the supplementation becomes less necessary.
Gosh, I'd love to have you come back and lead meditation just for an hour. Just lead us through.
Oh, I would love that. I'll take you through a whole class. We could do a video. I put my whites on.
Just get us in the mood, right? Get us in that good mode.
It's awesome. I'm a big, big, big fan.
I'm still laughing that you went to MIT and took the easiest degree, and it was neuroscience.
I'm not kidding. Ask anyone who's been to MIT. It's totally true. Course 9 it's called. It was like literally when you barely got into MIT, that's the major you did. So it's true.
I want to thank you so much for spending this time with us and lingering
My
for all the
pleasure.
questions. And it's really been a pleasure to have you with us.
Awesome. My pleasure to be here.
All right, I've got some closing comments, Dr. Brogan, so if you can hang just for a minute, and everybody else too. I'll be quick. I'm going to remind you about the survey to fill out after the webinar ends. Now, Dr. Brogan, I didn't ask you, but you've got a book out. Would you like to donate one to somebody in the audience? I'm putting you on the spot here. It's hard to say no, but
Oh, happily. No, I would be happy to do that. That would be, yeah, very easy for us to, and we can actually donate a couple if there's interest. And
okay.
I'll also offer that on my website, which is just my name, kellybroganmd.com, I have an ebook that is essentially a summary of the book that's available for free download anytime.
Okay, everybody go grab that and fill out the survey at the end, and you'll be put into a random drawing, and Alex and I will play with this in a couple days and let you know. We'll announce it at our next webinar. And Dr. Brogan will let you know so that you can either mail it out directly or from your publisher, however you want to handle that.
Sounds great.
Okay, everybody, I want to let you know about our next webinar. It's November 1st with Dr. Ann Shippey. She's going to be presenting on toxic mold. And this is a webinar and a topic I wanted for a while. I'm really glad to have it. You all have asked for it, so here it is. It really should be excellent. She's fantastic on this topic. We'll start at 3:50 Pacific time for our announcements, and hopefully we'll do a little interview with her too before we go live with her presentation. So I hope you'll join me for that segment too. And a reminder about our next All About Alumni is on Wednesday, November 2nd at 12 noon Pacific time with Rebecca Katz. So that, I'm going to say, concludes our presentation for today. So thank you again, Dr. Brogan.
Thank you.
You bet. And thanks everybody for sharing this educational experience with us. I want to wish you all the best of health, and I sure look forward to learning more together at Hawthorn University's webinar series. Until then, take good care.